breaking barriers and bridging the gaps between patients and doctors. Welcome to Brainstorming with the Docs and your co-hosts, Dr. Glenn Harrison and Dr. Kolby Condos.
All right, everyone, welcome back to this week's episode of Brainstorming with the Docs. I'm Dr. Kolby Condos, my co-host, as always, Dr. Glenn Harrison. How's it going, buddy?
Doing good. I'm doing very good. So
Part two
with Dr. Amigues.
Yes. So this part two, a little bit more clinical.
Mm-hmm.
Part one, if you haven't listened to it, go back and listen to that. That was all about her journey, how it impacted and shaped her approach to practice, how it impacted her personal life, her personal story, her backstory, the start to her hero story.
Mm-hmm.
So go back and listen to that and stay tuned because part two, here it comes. We're going to talk more about clinical approach and talk a little bit more after the interview. Here it is.
Okay, here it is. Some of it started with the naturopath, or a lot of it, and it came full circle to understand your health at a higher level, a much higher level than even what academia could teach you.
Totally.
And then you've been able, like you said, you've been able to apply those principles to the practice and see remarkable outcomes.
It's so cool. I mean, I have so many like little stories like that. If you want, we can share a couple. But
yeah, I'd love to get into that. But there was another thing. So now we know about your background and how you got to where you are and the courage to start a practice the way you have, which you're going to be extremely successful with. But a unique thing, and this is for a lot of people that are listening, when they start to have more abnormal, more aggressive, or the onset of inflammatory musculoskeletal joint issues post-COVID infection, or even maybe post-vaccine, something like that.
Yeah.
What do you see? What is, the question, which there's a lot of data, as you said, and we could go on for a long time, but what do you see post-COVID and all of these musculoskeletal inflammatory disorders? What do you see?
So this is a fascinating field. A lot of docs are shying away from COVID, but I think it's a mistake because we are learning so much. So the number one is COVID was a new virus, right? And so our bodies were not used to that type of virus. And every single infectious disease doc will tell you, and I did a little bit of infectious disease at first before I realized rheumatology was my passion. But every single infectious disease doc will tell you that what's happening is that we are a system where we need balance. And so we are constantly living with infectious agents. Like it's just how we are. We live with a ton of bacteria in our guts. We need them. Ton of bacteria in our skin. We need them, right? Like otherwise you have candida. And so we live in harmony with with viruses, with infection, with viruses and with pathogens, right? Like, and they're not necessarily pathogens, so they're bacteria and viruses and so on. And when a virus, COVID started, what happened is that it was new. And so a lot of patients basically developed severe reaction to the virus. And those were the young patients that would die in the hospital. And then we started having more and more connection. Like, so we got to know more the virus, and our system was still more and more in harmony with them, right? Like there's less and less severe disease, even in those that were not vaccinated. And the vaccine does the same thing, which is like the virus causes your system to wake up and go like crazy. If it's a new virus, your system really sees this as like, this should not be here. And so you can have, you can go from the minimum reaction, zero reaction. I've seen so many viruses, I don't care. I.e. the little kids in school, right? Little kids that were in school had no problem with COVID. They did not even realize, right? But like, that's their life. They are constantly in contact with viruses. On the opposite side, you had this, young men, 50, 40s, that were dying, like their heart stopped because of COVID. And it was all inflammatory. It wasn't per se the COVID, it was the reaction to the COVID from your system, right? So this is where rheumatology starts. because we started treating those patients with the drugs that we use in rheumatology. So we decreased their immune system. So when we started seeing that, we were like, oh, they need immunosuppressive therapy. They need steroids, they need tocilizumab, and so on. Well, so, okay, so those are like the, your kid, zero effect, and you're young and healthy, and then you get this horrible reaction, right? Well, there is in between, which is that if I stimulate your immune system and your immune system is stimulated, if somehow you have a background that's more prone to develop a rheumatologic disorder, you may actually develop a rheumatologic disorder. And so there is more and more studies that are showing that, yes, COVID can trigger rheumatoid arthritis. Yes, COVID can trigger ankylosing spondylitis or psoriatic arthritis. I don't think it's COVID causes. I think it's COVID triggers on a background, right? So
I
maybe
agree.
you have,
It's like bystander tissues being targeted.
Exactly. So, right, like, so it's like cancer. Like, not everyone that has BRCA is going to develop cancer. But if you have BRCA and you also like are overweight and I've never had kids, and like you add all of those risk factor, then you may develop breast cancer more likely, right? And so I think it's the same thing with COVID. Well, you don't necessarily, like, not everyone is going to develop a reactive condition, but if you have some sort of reason to develop it, you're more at risk.
Wow. So I imagine you've seen a lot of long hauler or post-COVID symptoms. What do you see clinically with regards to, like, for the people listening, certain joints? What patient presentations have you seen?
So so I see from very minimal to full-blown inflammatory arthritis. I will see like very minimal joint pain, muscle pain, brain fog being the worst. And, they have like the dysautonomia, so they cannot really exercise, the heart rate that goes like high and low and high and low. Basically, really, like, I see it as a dysregulation of our immune system that we just need to calm down. And sometimes it means that we do steroids. Some other time, I'm a big proponent of meditation, exercise, but slow exercise and so on. And those things are actually working. And then I've seen rheumatoid arthritis being full-blown because of COVID. I've seen myocarditis, so inflammation of the heart. I've seen every single inflammatory changes. And of course, because I'm a rheumatologist, I see more joint pain related to it. But so you can have so many things, right?
Yeah, even in clinic, what I see, the common symptoms, long haulers, what I see is a lot of cognitive issues, a lot of brain fog, and reduced neurological stamina, and then all of the inflammatory musculoskeletal pieces. Those are some of the big ones that I see. So when somebody has all of these things going on, another thing that I see, and maybe you see, well, then there's this disorder. So cardiovascular abnormalities, heart palpitations, that's a new symptom that flares up. And then there's musculoskeletal stuff, and that's a new symptom. So what I see, so I guess my question for you is wondering if you see the same thing, where you see multiple organ systems or tissue systems being turned on now, not just one. And then as a result, these patients are running to this doctor for that, this doctor for that doctor for this, and this doctor for that. It's just a storm of all sorts of. Do you see that as well?
Well, yeah, absolutely.
Multiple.
Absolutely. So it's because it's a rheumatologic disorder. At the end of the day, I call it a rheumatologic disorder, but like really what we're seeing is systemic inflammation. And so what's happening is that the systemic inflammation is causing one organ, then the other organ. It doesn't choose one organ, it chooses like all of those organs. And so, I think that the issue again is very little doctors are willing to help those patients because they don't have a lot to offer in terms of Western medicine medication. I mean, if you think about it, there's a recent study showing that metformin, which is an anti-diabetic, may work. And you're like, wow, that's kind of interesting that we are going to a drug that's,
it says may work. It may work. Is that?
I mean, you know, because when you have only one study, you have to like check and another one and so on. So it's not like it's not a medical advice. It's just like, you know, look, if you're overweight, it might be worth it to try that. Because, right, so inflammation that has been caused by COVID, maybe even more so if you're overweight, if you don't exercise, if you smoke, if you know, like there's so many reasons. And so that's what I'm seeing personally. But yeah.
So when you do see somebody in your practice and how you practice, and they're like, okay, doc, I have all this joint issue that's new. I also have heart palpitations that are new. And I also have brain fog that is new. And they come into through your door, you know, you kind of determine from the history, everything came on post-COVID. What do you start doing if there was something that, like, what is the direction you send them? Do you send them to multiple different professionals? What is kind of a case workup? What does that briefly look like?
So I think it depends on how, it's really a case by case basis, because it really depends on what the symptoms are. As a rheumatologist, if there is some sort of joint symptoms or fever, I'm going to address that because I have the tools to offer to address that. Now, if they have just a little bit of brain fog and just a little bit of, you know, shortness of breath and dyspnea, on, like, no, maybe I will not necessarily send them away right away, because, you know, I may be able to take care of that. We may do the test and then I still take care of that. But if their main symptom is shortness of breath, then yeah, I think it makes sense to send them first to pulmonary or cardiology, depending on which organ is affected. Because the worst thing would be to say, oh, this is only COVID or post-COVID, so there's nothing to do, right? Because there is, like, again, there are rheumatologic disorders that come out of this. And I can do a lot for patients with rheumatologic disorder. I mean, I can do a lot. Not me, sorry. Western medicine. there's a medications.
I remember you said that the types of treatments for these types of inflammatory musculoskeletal disorders in the world of rheumatology, people should. You told me something when we talked before.
Yeah.
That you said people should not have to live with pain.
Absolutely, I will repeat that.
And I think that's such I actually told Dr. Kolby about this after, and I think that's such a powerful statement, because the stuff that I've seen come through my door, nothing like yours, but I'm like, wow, that, and I'm kind of changing the path of our conversation, but that partially, if not a large component of being able to make that statement is because you are able to practice a different way. Would you say that's accurate?
Yeah, I think I've always thought that you should not have to live with pain always. I think the difference now is that I get more control for my patient faster, because I don't have to wait, you know, several months before I see them or see them at all. Like, I had some patients, like, they were only seen by other persons and not me, because, you know, they wanted me to see new patient, have a plan. And then I would sometimes have to wait 7 months before I saw my patient again.
You told me that was crazy. So briefly, if someone's listening to this, and I know there's not a protocol for everybody, but when you're managing severe rheumatoid in patients, you want to see them. How frequently would you want for you to be confident that we're hitting it with everything we have?
Exactly.
What is that increment?
Ideally, I want to see them at 1 month. So I'm going to start a treatment at 1 month. I'm going to see them to make sure actually that the treatment is well tolerated. Yeah. Because imagine the treatment is not well tolerated, then they have to wait 7 months without treatment.
I see it all the time, actually. But I'm not a rheumatologist. So I don't know how frequent. Crazy. So we've actually diluted that. We've diluted the expectations of what rheumatology could offer because of these confinements and these gaps. Is like over half a year before there's a pivot. In my office, which we do things completely different in functional medicine, I'm pivoting depending on what we're doing. I'm pivoting every week almost. It's crazy. Every weeks.
So yeah, not for rheumatology. Weekly would be awesome, but no, I don't think that I would offer much after a week, unless it's a new diagnosis, right? Like, so first visit, and then you do some diagnostic test, and then you have the second visit, which is like, hey, this is the plan. But once we have a plan, then 1 month, and then 2 months later, because at 3 months of a treatment, if it's not perfect, you need to switch.
This is very powerful. This is very powerful. People listening, because they're going to be in the medical system through that gauntlet, whatever they're dealing with these disorders. And then the doctor tells them, okay, or their insurance or whatever that regulating body is, saying, okay, we're going to follow up in 8 months or 6 months or 5 months.
Yeah, this is wrong.
You could have thrown 2 months of progress out the window, or 3 months, because you weren't able to pivot and modify. Would that be an accurate statement?
I think that, so yes, absolutely. I'm trying not to throw, anyone under the bus, because I think that the rheumatologists are trying to get their patients seen as soon as possible. So they are trying to put nurse practitioner and a physician assistant to help them. But at the end of the day, like, if you're looking at the perfect practice,
that's what we're here.
Right.
That's why we're talking.
So if we're looking at the perfect practice, in my view, someone that has rheumatoid arthritis, for example, right? You want to see them every 3 months, if not every 3 months, if not less, if they are not in perfect remission. And then the goal, and I always say that, the goal is to get to remission as fast as possible, so that then you don't need me.
Yeah.
Right? Because then you need me once a year. Yeah, exactly. Right. And so I have some patients that only need me once a year. And they don't really need me, but we're just like, hey, everything is still good. Okay, perfect.
Right. No, that's critical. And I think again, what we accept as normal in these different professions and different providers and different, strategies has been diluted of what the optimal should be or could be. Right? So it's not, again, we're not throwing anybody under the bus, any providers under the bus. We're really throwing the system, the accepted system under the bus. And I'll throw it under the bus every day of the week. I'm okay with that. It's not necessarily the providers, it's the system. So this is where your practice has come along. This is why it came to be what it was. So we're, again, coming full circle, because I know we're going to be kind of concluding it here. So this is part of the reason why you do what you do, is to be able to do everything possible to get people improving, health independent. Correct.
Absolutely. I think that I really see myself as, what is the tagline? I get patients with rheumatologic disorders to remission as fast as possible, so that they can live the life they were meant to live.
Love that.
And this is my tagline. I believe, I stand by it. I think that the goal is not me to tell them what to do, but rather teach them and show them that there are so many good ways to get to remission. And it might be remission with treatment. I'm not saying remission without treatment necessarily, but it might be remission with treatment, but still it's remission. Like, no one should have to live with pain if they have a rheumatologic condition.
Yeah, no, I absolutely love that. So where can people find you for information, to reach out, to pursue your care? I know I'm going to be able to send some people your way. I'm excited about that.
Yeah.
What would be the avenues? And I'll put all of the information in the show notes as well.
So because I'm out of network, which allows me to do this beautiful practice, no one needs a referral, which is great, right? So patients can actually reach out to me directly, and it will be like info@unabridgedmd.com. Okay. Or you can just contact us through our website. So it's unabridgedmd.com. Okay. And so, they can find, like, if you're interested in rheumatologic conditions, you can look at our YouTube and our podcast. So we have a YouTube, a podcast, that's the same thing. And you're going to come very soon. Yeah. And then we have Instagram, Facebook, all of those things.
Well, I'll put all that information at the bottom in the show notes. So one final question. I think this is, this is just from our conversation already. If someone has, maybe it's a very serious diagnosis, maybe something like you went through, or a very serious rheumatoid diagnosis where they're given a forecast of all of the dark doom and gloom, what would be, if there is one thing, what would be one thing that you would tell them after your journey that they could do for themselves to keep their mind in a different place? If there was only one thing.
So I believe this is the very interesting thing. I believe that our body is so extraordinary that because it can create disease, it can actually also heal them. And so I think that there's always a path of hope forward. Then the question is, what are we learning from this? What like if you have a condition. So I just want to say, because I could not hear you say rheumatoid arthritis that's so severe and they have a future that's gloom in front of them. That's BS. Press come and see me, because there's no gloom future if you have rheumatoid arthritis. If you have rheumatoid arthritis, we've got you. But if you have stage 4 stage 4 cancer or whatever, like anything that looks really severe, I do think really that there is a fear, and fear can kill us, and words can kill us. And so it's so important to be surrounded by hope, by people who give us hope, whether it's going away in the right way, in the way that you want to go. If you have, a neurological disorder that's like just getting worse. But really, I don't think that there is any disease that has no hope. I think that everything has hope. I've seen too many things in my life as a doctor that just gives me hope for everyone. Then it's a question of, do you want to leave or not? And that's really, that's what I would say. It's like, you have to find that, do I want to live? Like, do I have it in me that I actually want to continue and maybe transform my life for the better? But I think there's hope, always hope.
That's amazing. That's amazing. So I know after this, I feel more inspired. Like I said, your passion is intoxicating for what you do. So I'm very glad that you were able to join us, take the time and educate all of us, but also give us hope, because without hope, nothing happens. So anyhow, I guess I'll close for now, and I look forward to hopefully having you on the podcast again soon. We'll pick another topic and we'll dive deeper into your new practice.
Thank you so much. Yes, we love that. Thank you.
How was that? Super interesting, right?
Yeah, it was the conclusion to the second part of the interview. Going right from the beginning, right through from part 1 to part 2, she got into her story and how everything changed for her. How she saw cancer being her friend. Who would have ever saw that? I actually had to ask her about that a couple times before we did the interview, because I couldn't grasp the concept. And it was a naturopath that gave her that thought, that approach.
Right. It's there to help you and teach you something, and then it's going to leave. Right.
Yeah, who would have ever thought? So really, really interesting. And then in part 2, I thought it was really interesting. And I thought I was going to go with the interview into more clinical aspects of long hauler COVID. We spent 3 minutes on that because that's part of her world. But it was more about the necessity of hope for healing. And we've talked about hope on this channel.
Oh yeah, 100%.
We've talked about mindset. We spent a lot of episodes in one way or another talking about mindset, but it's really interesting when we see another person that started out, clinical practice completely different, and then how it changed, but she still has that overlapping, and she lived it, the necessity for hope and health. And then the other piece was really interesting. We were talking about how relationships with your provider is critical to your health outcomes. And then,
the thing I loved about her too is she's always like data driven, right? Mm-hmm. So she's like, and it shows here in this study, and this is the statistic. And I'm like, this is awesome. Mm-hmm. I think one of the biggest things that I took away from that is I think a lot of times we go, it has to be this or it has to be that, right? It has to be traditional medicine or it has to be, holistic. Well, she blends both of them. She does them all the time, and it's all about mind, body, and spirit. You know what I mean? Mm-hmm. And she talked about the importance of addressing all those, which I think is really awesome. Because I think that when you have all 3 of those different layers covered, the individual that's being treated or managed gets better outcomes because all of their needs are being addressed.
Mm-hmm. Treating people like humans versus projects.
Yes, exactly.
And she lived it, and now she
Yeah, she did.
So yeah.
So it was awesome. I love it. We should try to get her back on for something
we
else.
will. Maybe we'll get into something specifically clinical next
something
time.
specific, because I'm brand. She just bury us in some statistics
in data. But yeah, no, I look forward to the next one with her. Sure.
Yeah. If you guys like this type of content, or you have a topic you'd like us to cover or anything like that, you can reach out to us. Our contact information is info@brainstormingwiththedocs.com. You can get a hold of us on our website. Mine is northlakeschiropractic.com. Dr. Glenn's is drgharrison.com. We'll put her contact information in the description too.
That's
so if
right.
you guys would like to reach out to her directly or contact her office, you can do so. Otherwise, we'd appreciate it if you guys would hit like and subscribe, because we're going to continue to roll out new content every other week.
And hopefully interview more and more interesting people.
That's it. So till next time.
All right.
Talk to you later.
I look for the next one.